Welcome back to the Chatty Vets pod. I'm Brendan.
And I'm Charlotte. Thank you for tuning in.
And welcome to our third podcast of this month, our next 2 Week Takedown episode.
Yeah, this is where we aim to bring you up to date with all the latest news and products in the UK from the last few weeks.
We've got a busy show today covering plenty of topics from vaccination protocols, neutering controversies, and the big one, Brucella, and how we handle it in general practice.
Yeah, great. Okay, so let's get stuck in. So we're going to start off with something that we all do every day in general practice, but not necessarily something that we think about that often, vaccinations. Now, if you're thinking, oh God, this is going to be dry, bear with us. We're going to try not to make it dry. We thought we'd just take a second here to cover what we should be doing and why, and what companies are now doing in terms of what they're recommending and how that is relevant to us in GP practice.
Oh my God, it's been, everyone's been up in arms at where we are in what I work in a Linnaeus practice. And about a month ago, they brought in nationally that we all should be doing the WSAVA guidelines, the WSAVA guidelines for how we do our vaccines. And it's caused a massive uproar because basically we've all been vaccinating according to the data sheet for so many years. And now they're asking us to do a 16-week jab, a 6-month jab, and all of this. And obviously, if this is all the Linnaeus clinics, it won't be potentially that long before other practices are doing the same. And we're going to have to start. Now, look, as vets, we're going to have to start saying, well, why are we suddenly recommending something different from the data sheet? And a lot of vets on the group chat were saying that they're really worried that they're now doing stuff off license because it isn't what the vaccine manufacturer says. And it's causing like a lot of people a lot of stress. What should we be doing? So I think this is a really good thing to cover. What do we do? Do we follow the data sheet? Do we follow WSAVA? And let's look into this. Why are WSAVA getting us to do something different?
I mean, even when I was locuming at Medivet years ago, they still had recommendations from WSAVA versus the data sheets. But again, if you follow the WSAVA guidelines, then you're giving medications off license. So you have to have a discussion with owners. And they're like, well, if the data sheet's not recommending it, then I'm not going to do it because it means I have to come back more regularly and you're going to make me pay more money because you can't just give a vaccine for free, right? That's another thing is in this whole environment at the moment of us being like, we're not trying to push you to spend more money, but can you come back 3 extra times to have 3 more vaccines than actually what we were going to initially recommend to you? It doesn't put us across very well. So unless, like when practices have like a puppy vaccine price and it'll be, I don't know, 90 quid for 2 vaccines or whatever a company is going to put out there, unless we start incorporating into that puppy vaccine price, saying, you're going to have your 2 primary vaccines, a 16-week or 15-week and a 6-month, and that's all included in one price, I think people are going to just not want to come back. But I don't know. It's a difficult one to broach, isn't it?
Yeah, people really worry to go off license and having the time to discuss it because, they're now suddenly they're throwing another thing into our consult time when we've already, especially if it's a puppy back, because you've already got a million things to discuss.
And it is just a bigger discussion in general, isn't it? You want to cover food, insurance, vaccinations, neutering, flea and worming treatment. There's so many things that you want to go through, socialization, blah, blah, blah. And those things on their own are probably going to take you 20 minutes at least if you properly cover everything. So then adding in, by the way, we are now moving towards doing this. The data sheet says that we should be doing this, but now actually the guidelines are recommending that we do this. So what would you like to do? It just brings in a lot more confusion, doesn't it? And then it's who's at fault. If a puppy gets parvo and they've not gone for the extra jabs, is that the owner's fault, or should we have been? It's a bit of a muddied water, isn't it? Like if you're not recommending by the WSAVA guidelines, then are you doing the wrong thing? But you're still recommending the licensed form. It's really hard, isn't it?
The other thing is the whole vet team needs to know about this because someone will phone in with let's say they've got an indoor and garden only cat and it's 6 months late for its booster. Does it need to come in for 2 jabs? Or according to WSAVA guidelines, you might vaccinate them every 3 years. It might not even have to come in, or it might need to come in but not have 2 jabs if it's low risk. But they'll have to discuss their risk with the vet. So what is that vet? That receptionist has to have a rough idea how she's going to handle the phone call because the vet might go, but you might want to go to a category. You need an annual jab. We need to restart the vaccine because we have to fulfill the vaccine manufacturer's guidelines.
Yeah.
So
exactly.
It's something for the whole team need to get their head around. It is about communication and nuance because it's not black and white anymore. And this is what the WSAVA guidelines are kind of adding to our plate. And if you have 10-minute consult, it's going to be really hard.
Let's dive into exactly what we're talking about in terms of the difference between the guidelines and the data sheet. So if we take a look at dogs, for example, we all know core vaccines in the UK, obviously it's going to be different depending on what country you're working in, but core vaccines in the UK, you're looking at your DHP and your lepto vaccines. Now, DHP is your distemper hepatitis parvo. Your lepto vaccines, most commonly, I think most people are using L4 now, which is sort of the 4 serovars of lepto, but some places are still using L2, although I think they've stopped making it now, haven't they? But anyway, that's a different.
Charlotte, this is a disaster, isn't it? Have
Why?
you not worked in clinics where you've just managed to get all of your L2s onto the L4 and every consult you have to go, oh, we haven't got L2 anymore. It's happening the last year and a half to 2 years. I just think we've got everyone onto L4 and they've brought out a new L2. Do you know about
Oh, I
this?
didn't know they'd brought out a new one because I've been for years. I've been saying, "What are you doing? Get on
Devastating.
L4. You do not want your dog to get
Exactly.
lepto. If you ever see a dog with lepto, you would never vaccinate with L2 again." Is always what I say to my clients, and they're like, "Oh, okay, we'll switch to L4." I think I've sort of ignored what's going on in the L2 world because I've been I've been pushing L4 for so long. But anyway, so we've got our DHP and our L4 vaccines. Now, most of us, I think, in practice, based on what the data sheets will say, we'll do a vaccination at about 8 weeks of age in puppies, and then a second vaccine, so of both your DHP and your L4, a second vaccine at about 12 weeks so that you get the both. Some people do your DHP and L4 at 8, do your DHP at 10, and then your L4 at 12 so that you can sort of get them out a bit quicker in terms of socialization. Um, and then repeat both at the first year. And then you'd go for L4 yearly, but your DHP every 3 years. And I think that's what most people in practice have been doing for a really long time now, because that's what the
Just
data sheet
go
is
back over
recommending.
your extra jab thing again, because I've got a little thing as well, and we can
Yeah.
contrast them.
So I normally give owners the option when they come in with a pup for the first time, because we have that really tight socialization window, right up to 14, 16 weeks. So ideally, I like puppies to get out sooner so that they can socialize. So I normally give people the option of saying, let's at 8 weeks give them their DHP and L4. At 10 weeks, because DHP can be given 2 to 4 weeks later, right? So I tell them at 10 weeks to come back in and have the second DHP, and then they can go out a week from that date. Just be careful around anywhere that has a lepto risk, and then tell them to come in for their second lepto vaccine at the 4 weeks from the date, which is obviously what the data sheet suggests. So have that at 12 weeks, and then just say, it's going to be a few weeks after that, 3 to 4 weeks after that, you're going to have to be careful around lepto risk. So, I mean, that's what I sort of recommend to people in terms of socialization. Is that the same as you?
Yes, to some extent. The situation I tend to, I don't necessarily exactly, but my one is if they come in for their first jab and the puppy's 9.5 weeks old, and it just
Mm,
sounds silly to say, I will literally say, look, have you thought about just coming in 3 or 4 days when the puppy's 10 weeks of age, have your DHP L4 then? That means you've got a week before your parvo is covered. And I was exactly like you do. Maybe avoid really high risk environments, like if there's a park where a million dogs go, but you
mm,
can start the socialization, especially if it's a bigger
yeah.
dog and you can't get it out in your, what do you call those? A papoose or whatever. You know that when people put their puppy in a little thing and they
Oh, like
carry
a
them around,
sling thing. God,
sling
yeah.
thing, yeah. Do you know with my with our guide dog puppy, we had one of our friends lent us one, and us because the guide dogs I think you have to be they're really careful about. But I wanted to get the socialization going, so
Mm.
we got one of these sling things. I put her in it. I got all the way to the front door. I opened the front door, and then I was like, I can't do it. I'm too embarrassed. And I went back in. I gave up. It just
Yeah.
even from I don't know. Even for me, I'm not like the most kind of.
Yeah,
Oh
I do
no.
think they're a little bit like it's a bit like a handbag dog, isn't it? I don't know. I don't know whether I can bring myself to do it. I'd just carry it.
I tell clients, go to the pub, go to a cafe. I tell them I couldn't do it myself, but
Yeah.
so you're getting the full socialization impact. To be honest, I'm not often
Yeah.
doing an extra jab at 10 weeks, but I do occasionally.
Yeah. It just gives people the option to be able to get them out sooner, I guess. But and then the big difference that we're now talking about. So I think that's what we all routinely do. We all have our plan based on what the data sheets recommend. But the WSAVA since 2007 has been suggesting for dogs, the HP starts no earlier than 6 weeks of age, which is fine. That fits with data sheets anyway. But it's suggesting to start early and revaccinate every 3 to 4 weeks with DHP until they hit 16 weeks of age. They then suggest another vaccination at 6 months of age too, and then repeat every 3 years, as the data sheet suggests. But wait, the reason why they're saying that initially there's so much interference with the maternally derived antibodies from the mother that they interfere with the vaccine, which means that the efficacy of the vaccine that we're giving isn't that great. So they're suggesting we vaccinate for a longer period of time for it to be less likely that the antibodies are interfering with how well the vaccine works. But the thing that I find really weird about these recommendations is, if somebody knows why they suggest this, then please let us know. But whenever I have seen a parvo case, it's generally been in puppies less than 20 weeks of age, sorry, generally. That's generally known as sort of the most common time to get them, or in dogs that are sort of 10, 11 months old that had never had a vaccine. They're sort of the two categories of dogs that I've seen it in. So it sort of makes you question why they're suggesting a vaccine at 6 months of age, because surely at 6 months they're already out of that big window. And if they've already had a vaccine, then as they get a bit older, then they're not likely to develop parvo anyway. It just seems a little bit odd. I don't really know why they're suggesting that 6 month one. It's like there may be the 16-week one. I kind of can maybe get on board with the maternally derived antibodies being interfered, etc. But I think 6 months, like, what's the point? What are we doing it for at that stage?
Yeah, well, Linnaeus are pushing for that 6-month jab, and I'm a bit with you. I couldn't quite catch what you said. Were you saying that you're the because look, me and you probably do. I see lots of parvo when I'm working at one clinic where there's it's a lot of social deprivation in that area, and we see a lot of parvo, and
Mm,
we oftentimes we're seeing, I don't know, 2-3 cases every 2 weeks at least. So we're getting a lot.
yeah.
What are you finding? Were you saying that they're only ever unvaccinated and under 20 weeks? Is that your general experience
Not
for the
not
clinics you're
always. So
seeing?
I've seen quite a few that have had one vaccine. So, but usually
Yeah.
it's within like a week or two since their first vaccine. So
Yes.
I've seen quite a lot of that. But I've only ever had two cases that have been older than about 3 months or so. But those ones are always completely unvaccinated pets. But the majority of the time, if they're going to get parvo, it's going to be within the first 20 weeks of life. And if you've already given their primary vaccinations and you've given them an additional one at 16 weeks, by 6 months old, you're already out of that 20-week window. So, like, what are we vaccinating for? I don't get it. It seems a bit weird to me. Like, are people seeing cases at 6 months old that have already had their primary vaccination course? But I don't see the evidence out there or in practice that shows that that's what's happening. But I don't know whether they're just being super cautious, but it seems a little bit weird to me.
So this is what you're saying is exactly the kind of thing that I wanted to kind of simplify it down to, because it should be about what your practice is seeing. Now, when I worked in a clinic in Southeast London, in the 9 years we were there, we never had a single homegrown parvo case in the whole time.
Mm,
And we had the tests, we were looking for it. It wasn't there. But then I went 10 miles, 10, 15 miles to the east, and we were getting them frequently.
mm,
It depends on, so if I'm advising clients, surely I'm going to use my knowledge of what the practice sees to help them, because obviously we've got to balance socialization with risk. Look, I think the first thing to say is I don't think you're ever wrong following the data sheet only. But what you can say, and I think it has to be a really soft sell, but you could say, at this particular clinic, we do see a lot of dogs with parvo, and to be extra, extra careful, we can do an extra jab because some studies have shown that it's not always perfect just to have the two. But
mm.
so I think as long as you phrase it in the right way, uh, and like a lot of things, I feel like we can't oversell it. So I don't know if that sits well with you, but that kind of
Yeah.
phrasing according to the level of risk you're seeing in where you practice.
Yeah, 100%. So I'm working in North Wales still at the moment. And about a month and a half ago, I hadn't seen an increase in cases, but it just proves how crazy social media is, because every owner that was coming into the consult with me was like, "Oh my God, there's so much parvo in the area. Is my dog up to date with its vaccine?" And I was thinking, where have you got this from? I've not seen a single case in the last 2 months. You think, what are you talking about? But it just blown up because somebody thought their dog had parvo, or somebody's vet had said, your dog might possibly have parvo. They'd put it all over social media and everyone had gone, "Oh my God, there's parvo everywhere." And so everyone was coming in saying, "We need our dog vaccinated, blah, blah, blah." But I think, one, if there's a scare in the area, or if two, if you can say, I have seen quite a lot of cases recently, I'd really be recommending that we do this specific to the practice that you're at. That's very different than just saying, "Oh, these guidelines suggest that you should come in for an extra vaccine at 16 weeks. And then also at 6 months old, because people are going to be like, but why? Whereas if you can say, this is the reason why I'd probably recommend it, then that's very different, isn't it? So yeah, I
Yeah,
think it's
and
going to be
I
very,
yeah.
very area dependent.
Yeah, and I've been doing the WSAVA guidelines since 2008, 2009, or something
Mm,
like that. So I've been incorporating it. And can I just credit Linnaeus? for getting this debate going on and starting to
Yeah.
incorporate the WSAVA guidelines into general practice. Look, I think guiding vets on how we deal with it is great. But hopefully the way I've said, where it gives the clinician, on the ground, the freedom to
Mm,
kind of just pitch it at the right level. And
yeah.
credit to Linnaeus as well for it's incorporated into their health plan. So it will be costing them money to do the extra jabs.
Mm,
So, it's helped me because I've always had this need to bring up the WSAVA guidelines because I thought, well, if I haven't said something to someone, are they going
yeah.
to be, well, why didn't you tell us that WSAVA guidelines have been
Yeah.
saying this for 15, 20, 17
Mm.
years?
Yeah, it's like bringing it back to L4. So I always use Lepto 4 generally in terms of what I'm recommending. So generally I do initial dose at 8 weeks of age, and then depending on which one you're using, it's normally 4 weeks later, isn't it? Your second vaccine, and they say ideally as bang on the 4-week date as you can. And I think that pretty much fits the WSAVA guidelines with that. And they say, revaccinate annually rather than every 3 years. But I think it is this debate between should we be using L2 and should we be using L4. But I've seen lepto cases and you see how horrendous they are. And I think for anybody that's ever experienced lepto, I don't understand how we can not be recommending it anymore. But then maybe people just aren't seeing lepto cases. I don't know. And I think if that's what your practice is doing, if your practice is saying we want everyone on L2, so one of the places I work at, they use like a Connexin vaccine, which is L2 rather than L4. I personally will have the discussion with owners every time they come on and say, there's nothing wrong with the way you've been vaccinated before, but you've always been put on L2. I'd probably recommend we switch you on to L4. But then I've got no guarantee that the next vet the next year is not just going to put them back onto L2 again. So I don't know, it's a tricky one. I think you definitely need to have like a practice protocol so everyone's on the same page, don't you?
Yeah, the L4, we can get into the L2, L4 because I think that's largely breeder, isn't it? Usually it's the puppy owner
Mm,
goes, "The breeder told me not to have L4." Um, can I tell you about the very first L4 injection I did though? All these
yeah.
like 2018 or 19 or whenever it was. The first L4 I did, the head swelled 10 within 10 minutes. I think I'm adding
No.
to the drama. Maybe I shouldn't say this because it's gonna add
Yeah,
to the
don't add
fuel
to the
fuel the
drama.
fire. Oh my God.
I've never
I
had a
am
reaction, just
I
saying.
am I am a evil. I'm just stoking up the argument. But it happened. I'm going to say. So, I gave my first ever L4. Gave it. Head swelled up. By the end, bear in mind my consult's gone forever. Within about 10 minutes, the face started swelling up. Took the dog back. IV antihistamine. IV.
Yeah,
I can't. I think I did IV antihistamine. Wait and see. And I was ready to do IV steroid if needed. And I don't think I
yeah,
did because it settled. But
yeah,
never since. But
yeah,
it
yeah,
was my very first one. It's so weird.
yeah.
But it could have had the same reaction to L2. I don't see why. But
Oh,
I think
100%, yeah.
when I looked it up, they had formulated it in a different way to kind of create a little bit more immunity. So, but something I learned more recently on a message board was that that particular puppy was one of those color diluted miniature Dachshunds,
Oh, okay.
now now let me I think color dilution could be a risk factor for allergic reaction, and I think maybe even miniature da I keep talking about miniature dashes at the moment, but maybe people can come into me on that and just tell me if I've got that right. But I remember thinking back to that puppy swelling face incident, thinking,
Yeah,
"It was
yeah,
color diluted miniature dachshund." That could
yeah,
be the
yeah.
risk factor there more than the L4.
Yeah, yeah, maybe. But I think ultimately, I always warn people there is always a risk with any vaccination. You never know who's going to react and if they're going to react. So, but for the majority of vets, we've all seen cases where things haven't been vaccinated and they die from parvo or they die from lepto, and it's just not worth the risk. And I think because I feel so strongly about it, that comes across when I speak to clients as well. So, form whatever opinion you're going to have and make that opinion quite strong. And then when that comes across to your clients, it will help to get them on board with you because they're going to see how clearly passionately you feel about it. So, but there we go.
Shall we go into how much lepto is in clinical lepto cases are from the strains that we're not protecting and how much are
Mm,
from the original two strains, Bratislava and I don't know, what is it, Autumnal? No, it's not something like that. From those two original strains, because I think that's a really interesting thing. Because wouldn't that, if we
yeah,
had that clinical info and we said, well, 30% of natural infections are from the two strains we're not protecting. But I
yeah.
don't think we
And I think
actually do have it, do we?
I don't know. And to be honest, even I think it's also worth remembering, even if you're fully vaccinated with L4, dogs can still get lepto because, yes, you're vaccinating against the 4 what is perceived as most common strains, but there's still going to be strains you're not protecting for. So, and then the difficulty then comes with if you vaccinated, whether it's L2 or L4, it's trying to work out whether it's bloody got lepto.
It
Because if
sounds like
it's
you're promoting for an L6 when you said there's strains that we're not protecting for. Is that
no,
true?
no, because
Don't put us through another vaccine change, because
yeah,
that was hard enough.
it's then like trying to work out because if you do think you've got a lepto case, it's then thinking, right, okay, well, if I do serology, it's going to come back as antibody positive because obviously it's been vaccinated. So is it to do with the vaccination or is it to do with the infection? So then you have to think about PCR. It just makes it really difficult, doesn't it? But I think by that point, I'm like, it's probably lepto. I should probably refer it anyway, in which case it's their problem, not mine. But yeah, I don't
It's a
know.
NAF diagnosis, isn't it?
Yeah.
They used to say dark field microscopy on urine, but I think that's been
Okay.
ditched now because it was too difficult to do. So that I think that's gone. And like you say,
Yeah.
and then PCR doesn't distinguish what serovar it is. So then you don't
Mm,
know which strain. So I think that these are the reasons why. And then I do see clinics going, oh, they've got a serology positive, but it's got lepto, when it probably hasn't because it's like vaccination. But then you've got oh god, we're going to come into this with Brucella later, aren't we? Because there's the health and safety aspect, and that is genuine.
yeah.
We've got to be careful about health and safety, but then it's balancing that with causing alarm and panic.
Yeah.
So, if we have a serology positive lepto, well, we have to be good with our health and safety, but we
Mm,
also have to have in mind that it might not be lepto.
yeah.
And it's again, it's that nuance balancing.
Mm. But
Yeah,
then
that
also, I think
all of
lepto's
that.
a bit different in that, yes, it's zoonotic, and yes, in theory, someone could get Weil's disease by coming into contact. But you're not going to get contact from just touching the dog. You're going to get it from coming into contact with things like their urine. So realistically, unless their urine is coming into contact with, I don't know, your conjunctiva, your mouth, or like I don't know, an open sore or something like that, then I think it's not like it's airborne, is it? It's not like we have to be that careful. But yes, we do have to bear in mind that it is zoonotic. So it's something to be, but I think everyone's like, "Oh my god, hazmat suits and stuff," and I'm like,
Hold
really
on,
doesn't need to be
I've
that
got it. Hold
crazy."
on. You know when you put the UCath up, the penis, to get the urine
Yeah.
sample, and when you take it out, do you find I always get a bit flicking in your face or in the nurse's face? Do you not get that? You pull the last bit
We
of the
can use
urinary
those
catheter out, and it
use those
flicks.
use those COVID masks. You know, they're like
Yeah.
clear ones that we always still use. Yeah.
Yeah,
Anyway,
you're too careful with. And the other one, they always say, I don't know if this is true, isn't it? But when they wee on concrete, it can kind of aerosol up, and you might breathe it. And then you don't hose it away. You kind of use a bucket of water, so you don't kind of aerosol the urine up and breathe it in. But I mean, they're marginal risks, but you just do it. No, I'm a big fan of L4. I should say before I know about what I said about the puppy, but I'm a big fan of L4. Can we just quickly say as well, because lepto is a bacteria, the vaccines against bacteria are never as good. And this is how I
mm,
remember it. And that's why we need 2 jabs to get solid immunity. Whereas the DHP, the one vaccine is enough as long as there's not MDA, as long as there's not the mum's antibodies still swirling around the system. So the puppy's old enough,
mm,
one jab is enough. And because they're
mm,
viruses and virus vaccines work better than bacterial vaccines. Is that
yeah.
kind of, I mean, it
Yeah, but
doesn't apply to
you
kennel
don't. I
cough,
mean,
but
yeah, but you don't want to be waiting till 10 weeks to vaccinate a pup, do you? So I think that's why we always do like multiple of them because you want to try and get it on board early. So, you
yeah.
know,
Yeah, in
yeah.
case the
I
MDA
think
falls off sooner.
yeah,
Definitely.
exactly.
I'm with you
Exactly.
there.
Okay. I think maybe just before we move on to cats, maybe we should just have a quick ode to kennel cough, just have a quick chat about it. I mean, it's not considered a core vaccine in the UK, but I think we all use it quite a lot. The big thing to remember with kennel cough is obviously the majority of them are going to be intranasal. So you sort of use that aerosolized spray stuff that they all hate up their nose. Which little tip, if anybody isn't doing it already, anybody who really struggles to give them a stroke on their head with your left hand, then cover their eyes with your left hand and then give the vaccine with the right and they don't know it's coming before you've done it. Anyway, little tip. But the big thing to remember is that remember to be talking about whether the people that are in contact with that dog, remember to ask whether they're immunocompromised or not, because I mean, I don't know how often it happens, but there is obviously that risk of the fact that we're giving a live vaccine. So, to anybody whose immune system is super suppressed, there is always, in theory, the risk that they could get Bordetella or something. So, it's just worth bearing in mind.
Yeah, a lot of people are really good at that, but I'm not one of them. We're chatting to Bradley Viner, who's in the disciplinary panel for all of this, and I mentioned it
Mm,
to him, and he was like, yes, you really must make sure your notes have got that you've mentioned it. And I thought, oh
Yeah.
God, I've got 25 years of failing too. I've been awful at
Yeah.
that. And I know even now I still forget.
The one thing I would say is I didn't believe any of this immunocompromised stuff. I was like, oh, I'll say it, but like, don't really have to be that careful. And it's for like, it's quite a long time afterwards. It's for like 6 weeks or something. We have to be
Oh
careful,
my
isn't
God,
it?
it's
But
ridiculous. Yeah.
yeah, but actually, I had a lady come into me.
God, this.
She was really stroppy, like really stroppy. And anyway, I remember vaccinating her dog, and I'd had the discussion with her. But she'd got a bit of the kennel cough vaccine on her hand as I'd vaccinated the dog, and she said she wasn't immunocompromised. So I was like, "Oh, don't worry about it. Like we get it on our hands all the time. Like it's not something I'm worried about." I think I don't know whether she went to
We
wash her
breathe it
hands or
in
she was like,
every
"Oh, I'll
day.
wash." And I was like, oh, well, well, you can wash your hands at home, whatever. I can't remember. I just like laughed about it and she wasn't bothered in the consult because I was like, you spray it up and then they sneeze it and it goes everywhere. Anyway, she came back to me a week or two later and was like, you've given me kennel cough. I was like, what do you mean? She was like, I went to my doctor's because I got a cold 4 days after the vaccine and he told me that I've got Bordetella. And I was like,
Love it.
what? When you think, really? I was like, oh, I don't know if I believe you. And then I was like, also, please don't come into the room and cough all over me if you've got kennel
Yeah.
cough. I don't want it. I was like, go away. I don't want human kennel cough. But yes,
Oh my
so
God.
apparently it can happen. And apparently I've done it to someone, so just be careful.
Were
I
you
was
on the
like,
phone to the
really?
VDS at that point?
No. No, I was like, she's got a cold. She'll be fine. She's not going to die, is she? She'll be fine. I don't think
My
she's
God,
dead. She's
that's
fine.
funny. Well,
Anyway,
we need to
but
check this before this episode goes out. You won't be laughing then, would you? Oh, God, what a terrifying thought. No, don't, because
oh my
this
God.
whole laughing bit will be, and then the vets were laughing, and now she's
Do you know
dead.
what? This is really off topic, but I have to tell you because it's awful but really funny. I I was working a few weeks ago in the place I'm locuming, and one of the other vets came up to me and they were like, Charlotte, do you remember just before Christmas you called someone to tell them the results of X-rays over the phone? A really old man, and I was like, oh. Maybe. I can't remember. And she said it was something with a cruise ship. I was like, maybe. I said, what dog was it? And she was trying to explain, and you're racking your brain for the case. And I was like, yeah, maybe, like vague recollection. She said, do you remember what you said on the phone to him? And I was like, no, I think I just told him that the dog had a cruise ship. And she said, the lady's not annoyed, but she said this lady, like, I don't know, 84, 85, something like that, came in with this dog. And she said that I'd called her husband to tell her that the dog, she didn't know what I'd said over the phone because she hadn't had time to chat to him about it. He went to bed that night and he never woke up. He died. So she was like, oh my God, what has the vet said to him over the phone? Is it something really bad? Basically saying, have I killed her husband because of what I said? And I was
God.
like, my God, what have I said to this poor man? And you're like, oh God, I've killed him. I was like, what? What's going on?
God.
But yeah, never had that before. Yeah. Euthanized many an animal, but never
Oh
been involved in people. Oh my God, it was awful.
my
But anyway,
gosh.
yeah, that's scary, isn't it?
I'm a bit worried about myself now talking to you.
I know.
I don't know.
So just, be careful what you say on the phone, people, is what I'm saying.
Yeah.
But
Yeah.
anyway,
Definitely. I do. Yeah.
okay, so we've covered dog vaccines. Let's go on to cats. So in terms of general core vaccines in the UK, we all know we're talking about RCP and FELV. So RCP is your cat flu stuff, so your rhinotracheitis and calici, and then you've got your panleukopenia, FELV as well. I think most of us with the data sheets will give our first vaccination about 8 to 9 weeks of age of both of those, then a second vaccine of both of those 3 to 4 weeks later. Repeat both of them at a year, and then generally people, depending on what combo they'll use, will either do RCP or DUCAT if you've just got the cat flu component that you can use, do that yearly, and then the sort of panleukopenia component and the FELV component every 3 years. I think that's what most of us do, right? But the WSAVA, again, have a slightly different routine that they suggest. So for RCP, they say start no earlier than 6 weeks of age, fine, but revaccinate every 3 to 4 weeks until 16 weeks of age. And then they suggest, apparently, for RCP to be revaccinating every 3 years unless they're at a higher risk, which I thought was really weird. FELV, they say start as early as 8 weeks of age, second dose 3 to 4 weeks later, then every 3 years. So in theory, they're potentially saying that both of them only need to be given every 3 years. But they're saying that sort of your high risk environment are things like multi-cat households, if they ever go into catteries, etc., which is, I think, why we're giving the sort of cat flu component more regularly. And to be honest, with the data sheet, it doesn't quite fit. So if you're not giving it as often as the data sheet is recommending, then obviously you're giving it off license. And if it gets some sort of infection, then I think maybe we're at fault there. So it's something to be aware of. But what do you do, Brendan, in terms of, the people that come in and say, oh, my cat's completely indoor? What do you suggest that they should be doing? Because I still say it needs to be vaccinated every year because there's always a risk. But I mean, what do you do?
I look, oh God, my bosses listen. If there any bosses listen, try it. Actually, I've got to stop saying that because they're probably like not even properly listening, and they hear that and then they're like, right, what's he going to say? I do have a problem because obviously I've been following the WSAVA guidelines for so long, and I basically have a real. So normally I'll be saying something like WSAVA guidelines and all the other major cat organisations. By the way, I mean it used to be
Mm,
ABCD, which is another of these cat disease kind of organizations, and the American AF, the Association of American Feline Practitioners, they all have the same guidelines. So indoor cats, if you're in a closed group, perceived very low risk, maybe you're not even in a group, single cat household or whatever, because I think as soon as you're getting more, you might have a healthy carrier. But all of these kind of low risk situations, they were saying every 3 year vaccine was, balanced vaccination with
mm,
risk. So I would say that to them, but I would say the next vet you get might want to restart your vaccine because you're not doing what the data sheet says. So I'll tell the client, we've got two rules here. We've got what the data sheet says and what a lot of the big organizations around the world are saying. And I said,
yeah,
if you just want an easy life, you might just want to come in for an annual vac because not everyone's going to be like me. So that was kind of a little bit of my comment. And then I'd also say to them really carefully, look, if you ever want a cattery in a hurry, you really want to just get that vaccine done every year because for the cattery,
mm,
we have to fulfill the vaccine manufacturer's guidelines, which is an annual
yeah,
jab. So it would lengthen my consult, cause the owner a little bit of confusion, and I probably didn't succeed in achieving very much, other than just
mm.
making myself feel better. That I was kind of relaying a guidance from really important cat organisations.
Yeah, yeah. I think it's very clinician dependent, isn't it? And also depends on how much you're seeing it and very much to do with what the people and the cat have planned. Are they never going to take it to a cattery? Are they a single cat? Do they never come into contact with any other cats, etc.? Then yeah, I think it's more sort of a discussion to have with owners, isn't it? But I think I don't know. I'm someone that just goes, well, for me, the risk of vaccinating is small, and I'm like, well, if you get a cat that has recurrent bouts of cat flu their whole life, it's a pain in the bum, isn't it? So I just think, well,
Awful.
just yeah, I just think just vaccinate because then you don't have the issue with it. And I think I definitely am one for I love giving Ducat yearly. And then the other stuff every
Yeah.
3 years, rather than giving everything. Because a lot of people just give leukophilin every year and just go, just have the whole lot because it's easy and it's
Yes.
licensed, it's fine. So I think that we can be more careful with it. The other thing is as well is trying to convince a client to come in for an annual health check if they're not going to have a vaccination is quite difficult. So it also means that it's a yearly point that we can check back in on those patients and say, are they losing loads of weight? How are their teeth? It's a good point for us to be rechecking them back as well as doing that preventative healthcare in terms of vaccination. So, and in flea and wormer, we're going to need to be seeing them to be able to dispense their flea and wormer. So for me, it just makes sense. But I think we can be more sensible about what we're vaccinating and when.
I'm with you on that. I like what you said. And I'm also share your thing about the Ducat, Tricat so easy. This is another thing to bring up, actually. So we change brands when they're adults, and I think that's okay. And it's actually perceived as potentially beneficial. However,
Mm,
we don't change Vax brands for the initial kitten puppy jabs
yes. Yeah.
because we want to potentially trigger that increased reaction to the same antigens. Is that's the basic plan around that?
Yeah, 100%. And it's all about licensing as well. Like it's not licensed to give one type of vaccine and then 3 to 4 weeks later boost it with a different type of vaccine, unless you have the ones that are completely compatible. Like some of your Canagen and your Novavax ones are fine together, aren't they? But just check your data sheets with things like that just to make sure. And if you're ever unsure, say that you don't think it's incompatible and restart them just in case because you want to cover your
Hey,
ass basically. But
but nowadays it's so cool because you can go when if a client's getting a bit arsy about having to do an extra vaccine, you just
mm,
go, well, but do you know what? It's really good you come in and have another jab about 15, 16 weeks because that's what the WSAVA guidelines are saying is for really good immunity. So
Yeah.
just do it anyway. And I did
Yeah.
that the other week, and a client was like, "Oh, okay then." Yeah. Anyway, cats, indoors. Yeah.
Yeah.
Same as you actually. And sometimes the client will say to me, "Oh, you come in for the annual health check, blah blah blah." I said, "Yeah, but to be honest, it's about the same price. I think you say it's only about £7 less." And they're a little bit like, "I might just do the annual vaccine then."
Yeah.
I
It
think
just
so.
makes sense, doesn't
Yeah,
it?
yeah, yeah. And then I've
Yeah.
just blown 5 minutes of my consult time. But there you go.
The other thing to think about when we think about cats and dogs and vaccinating, when to vaccinate them, is also when to let them outside. So I think for dogs, the majority of us are saying after they've had their second DHP vaccine when they're a puppy, they can go out a week from that day. But be careful with L4 because I think the DHP data sheets say that if they're immune or should have enough immunity a week after the second vac, but for L4, it can take about 3 weeks after the second L4. So just be careful. In cats, to be honest, I've never really looked it up because I always wait for them to be neutered anyway. And generally, they're being neutered after their vaccines. But if you ever have anybody ask, the TriCat data sheet says about up to about 4 weeks after vaccinating before immunity properly kicks in. So be a little bit careful with when you're saying to people to let their cats out. But obviously, ideally, we want them all neutered anyway, because otherwise they're going to go out and get pregnant or start seeing all the other ladies around the town and doing their business. So yeah, ideally neuter before they go out, get them chipped before they go out, obviously. But ideally, if they're going to be vaccinating late for whatever reason, then just make sure that they're waiting at least 4 weeks after the second vaccine before they're letting them outside. Cool. So that's cats and dogs. I think maybe quickly we should just cover rabbits. Obviously, rabbits generally we're trying to cover for rabbit hemorrhagic disease. And we're also trying to cover for mixo. So they're the two big things that we cover in the UK or try to cover in rabbits. Generally, we'll use that sort of, is it Mixo RHD plus? Is that what it's called? And it contains the RHD virus 1 and 2 components plus the Mixo. And generally, you give them from about 5 weeks of age. So you give one vaccine. It's not like dog and cat vaccines where you need to give a second one a few weeks later. And then you just vaccinate them every year for the same thing. Worth talking to clients when they come into you with these to have these vaccinations as well. Make sure you remember to mention fly strike prevention every time they come in as well, because that's something that we see obviously all the time. So wangle that into your consults as well. But generally, they say for rabbits that the onset of immunity is 3 weeks after that first vaccination and it lasts a year, which is why we need to be vaccinating them yearly. But there was also that new vaccine that came out. I don't think it was last year, it might have been the year before, or it was early last year. It's that Yervac RHD vaccine. So it's the new, more virulent strain of rabbit hemorrhagic disease that we've been seeing. And although it doesn't cover, so your Mixo RHD Plus will cover everything else that you need to be worried about. But in terms of the new virulent strain, it's now suggested that you give it about 2 weeks after the initial vaccine. So a rabbit will come in at about 5 weeks or onwards. You give them the one vaccine with everything. And then at least a couple of weeks later, they come back in and have the Yervac RHD vaccine. But the difficulty is then if they're coming in every year, are you then saying every year you need to come in for two separate appointments 2 weeks apart, which becomes more tricky. But I think because there's definitely a lot of committed rabbit owners out there, so I think it's worth talking to them about it, because if a rabbit gets RHD, it's not going to be very nice. So yeah, it's something that could be worth talking to owners about.
No, okay, that's cool. That's a big deal.
Yeah.
And another one of these nuanced ones. If it's a bunny, perceived low risk, let's say you do get the people that don't let them out in the garden at all. Indoor rabbit, perceived low risk,
Mm.
don't bother with the extra VHD. I don't know. If the owners don't want it and they can't be bothered, I don't know.
Yeah.
But if it goes in the garden
Yeah.
or you've got a high risk breeding colony, well, yeah, let's get it done.
Absolutely. It's
But
just a
there's a bit of
discussion. And
another
ultimately,
chat.
yeah, ultimately, if you've offered it and they say no, it's up to them, isn't it? But if you've offered it, then
Mm,
you write in your notes
yeah.
that you've offered it, and then you're covered. So yeah, but there we go. Okay, the other thing that I wanted to mention here when we were talking about vaccinations, Lucy on Instagram, thank you Lucy for sending me a message a little while ago. She sent us a reel about, I have always done since uni, I've always drawn up my vaccine in a green needle, discarded the green needle, and then put a blue on to then give the vaccine, or an orange if it's a rabbit. But I've always done that because I've always been like, it blunts the needle and it's infection risk. But apparently, there's now been a paper that's come out that said that there makes no difference in terms of what the animal feels, like the blunting doesn't make any difference. So maybe we shouldn't be changing them. And in an environment where we want to be saving on waste, maybe we shouldn't be doing that. So maybe we should just be spraying the bottle with a bit of spirit or something and then using the same needle. But I don't know whether anybody else does this. I just thought it was worth mentioning. So, but I always change the needle, but it's because it's what I've already done, always done. So
Yeah, I changed the needle. The biggest thing is is making sure the patient is relaxed. And oh my God, Carl, can I do a rant? My opinion about this is if you say, don't worry, just a sharp scratch, and you say it in a tone of voice that's always a little bit higher in pitch, always a little bit faster in rhythm, and you go, don't worry, just a sharp little scratch, the animal tenses up because they think, I know what that tone and that increased high pitch means. It means something bad is going to happen. So now I'm going to tense up a little bit, and anything that I do feel, I'm going to react to and feel more strongly.
Mm.
When I'm doing my vaccine injection or my IV cannula or whatever, I will keep the conversation going, and I usually give the owner something really juicy to talk about. So I might kind of just set them up with an open question about something I know they'll want to talk about, so that I can
Mm.
get their rhythm and their conversation at that conversational tone and speed. So I've got this
Yeah.
background of them chatting as I do the injection. And I find it just goes so much better. That's more of a factor even than the needle. Do you get this? But if every bloody vaccine I went, oh, don't worry, just a sharp scratch, they're all going to be bloody tensing up and feeling it. No? Is this, tell me, am I off on, is
No,
this
I don't
another
know.
thing
I've
I'm
never
doing?
really noticed it, but I think it's because I just do it. I probably do what you do without even really noticing it because I make it not a big thing because I'm like stroking the animal. I draw it up, I stroke them. I'm just talking to the owner, and then I give it while I'm chatting. So it's like and then people are like, "Oh, it's already done." Like it's because the owner hasn't even realised. So it just makes it all a bit more natural rather than being like, "Right, I'm going to give the injection now." So I think I'm doing what you're doing without even noticing.
Anyway.
Yeah.
Right. GGGV20? Oh,
Yeah. So I hadn't heard anything about this. The girls that I was in the practice that I was locuming at, or am locuming at, were talking about this new GV20 injection site. And I was like, what the hell is that? Thinking it's some like viral trend that people are doing. But actually, people are doing it and it seems to really work. I find it weird. So if you haven't heard about it, it's this apparent GV20 injection site, which is on top of the head, which you're supposed to say that you can do vaccination, sedation, all this sort of stuff in it. And it's called the Governing Vessel 20 acupuncture location. They say that it's located on the dorsal midline of the skull, just caudal to the point where the imaginary lines from the rostral ear bases meet. So it's sort of like the top of the forehead, if you want to call it that, or like the back of the head. But apparently, dogs and cats seem to tolerate it really, really well. And apparently, as well, if you give sedation subcut in that area, apparently it's supposed to work. Well, they said there was something that I found that said, I'm just reading it now. I said, sedation via the GV20 injection was similar to, but more consistent than IM injection. So potentially they're sometimes saying that it could work better than your IMs, but maybe that's because there's not really as much fat on top of the head. So in your really chunky patients and you've just injected intra fat rather than IM because they're so chunky, maybe that's why. But yeah, I just thought it was really interesting. And they said
so
that
subcut at the top of the head or into the
yeah,
muscle? Sorry,
subcut.
you said
No,
subcut.
subcut.
Yeah. Okay.
Yeah, subcut at the top of the
I'll
head,
try it.
and they say yeah, and they say apparently they looked at site temperature or something like that in between there and muscle, and they said that apparently it's got greater perfusion in that GV20 site, which apparently potentially explains the difference between because apparently they say that it does better sedation but with less nausea and vomiting, and they say that maybe that's why because it's got better perfusion. I don't know, but it just seems a little bit weird. So if anybody is routinely doing it, then let us know because I just think it's really interesting. It's like a completely new way to jab them. But I don't know how owners would perceive it if I'm just like, well, I'm just going to lift up the skin on its head. It's going to look like you're injecting its brain or something. They're going to be like, what are you
Yeah.
doing? So, especially in a cat, I find it really weird, but I don't know.
Oh, yeah. I like
Yeah.
this though. No, I'm definitely going to give this a go. I was all ready to poo-poo it, and
Yeah.
I was going to make a cheap dig actually and say I've got something even better than what's it called GV20,
Yeah.
and that is Licky Licks for dogs and cats.
Yeah.
Do a
Yeah.
Licky
Yeah.
Licks. I've done like 2 microchip injections. Kitten's not turned round. Just been gobbling
Yeah.
up the
Yeah.
Licky
Yeah.
Licks. That is
But I think it's
amazing for vaccines.
yeah, it's more talking about sedation and stuff as well, I guess, isn't it? But I mean, it's saying that you could vaccinate them in that place as well. So I don't know, weird. So
We need to
weird.
talk about very quickly. I've been vaccinating my cats in their back leg for
Yeah,
maybe 20 years. So yeah, is this what you do?
I don't, to be honest, and I just do subcut. But I think the problem I've always had with it is if I start vaccinating in the back leg, because we're trying to avoid injection site sarcoma, right? That's the reason why we're trying to avoid it,
Well, we're
because we
trying
know
to
that
have it amputate the leg if it comes
yes,
if they get
exactly.
injected
Yeah,
straight on the
because we're
leg.
saying exactly. Yeah, because you
Yeah.
can't amputate the neck, so it's a bit different. But the difficulty that I have is that if it's not a practice policy, the next year that they go and see a vet, if it's not you, if they then say, "Oh, the last vet gave it in the back of in the leg rather than in the scruff of the neck because they told me about the risk of cancer," if that vet doesn't feel comfortable like vaccinating subcut on the back leg, you've then got a really tricky conversation to have. So for me, I feel like it has to either be a practice policy or you don't do it.
Oh yeah, I don't. I hope I don't dump people in it. I actually just find it works really well.
Mm,
It took me a few. It took me a look. There's a period of adjustment. It took me I don't know, a few months or whatever to get used to doing it. But if for not it's not for every cat, but for 95% of my cats now, if you get them in the right position, they actually quite like it. I just do it.
mm,
Yeah, I do it thigh. I pinch the skin up and inject, and because you're away from their, sometimes being away from their face is good.
yeah.
I don't really say much about it, or I'll just say, oh, it's a tiny bit safer if you do it in the back leg. People say, but it's not a big deal.
Okay, so moving on from vaccinations and injections, etc., we have done our classic thing of becoming extremely irate about a topic and talking about something for like an hour when we thought we were going to talk about it for about 15 minutes. So we were going to cover controversies in terms of when to neuter and the difficulties of neutering, what's more likely to happen in dogs that are neutered early versus neutered late, etc. We are going to cover that in a future episode, hopefully coming up very soon. We wanted to talk about something that is becoming way more emerging in the UK and something that is becoming a little bit more scary, a little bit more on our radar in terms of something we need to be checking for. Brucella.
So the problem I'm seeing in corporate in Linnaeus practice that I work in is, I suppose, there's a lot of clients that have had a rescue dog from 7 years ago. They've been coming to the vet for 7 years, and now they're suddenly being asked, "Yeah, have you had a Brucella test?"
Mm,
And they'll often go, "Yes, I have." And then they'll go, "But was it 3 months after you came back to the UK?" And then they'll go, "No, it was a transfer into the UK." So then they'll be like, "Well, we can't see you until you've had a Brucella test. We have to wear full PPE when you come. We have to not have you at the middle of the appointment block." So it's causing a lot of stress because, once again, you get this rule from above, then we have to deal with the client that's suddenly like, "Well, what's
yeah.
changed? I've had the dog 7 years. I'm sure it hasn't got Brucella." And I think deep down they must be slightly worried. But have they
Mm,
not told me that my pet has Brucella? And what is this
yeah.
Brucella? So I think suddenly it's one of these things on my mind. Like, I need to blooming get my head around this because it's starting to impinge. I can't hide away from it now. I've got to deal with it.
Yeah.
Have you had the same? You've not quite had this yet.
No, I think to be honest, but maybe it's just because I've not made myself more aware of it. Like, how many pyometras do I see that it doesn't even cross my mind? It's really bad. Exotic diseases and diseases that are coming from outside the UK are becoming so much more prevalent. I think we all now need to be changing our tactics in a consult. In every history taking that we do, we should be asking, has this dog ever gone outside the UK? Really? Because, and cats as well. I mean, obviously not for Brucella, really, but we should be asking, is there a history of import export? Because that can really change what's going on. And I think we should be more aware of this. Like, we could have done surgeries on dogs that have had Brucella and not even know, which is really scary. In terms of what we're potentially gonna what we need to do about it, what we need to think about in practice, maybe we need to go back slightly to exactly what it is and why we should be worried. So remember, Brucella canis, which is the Brucella that we're worried about, is an intracellular bacteria which causes canine brucellosis, which is an infectious disease mainly in dogs, but it's zoonotic, so it can also affect humans. But the thing that's worth mentioning is that B canis, which is obviously the type of Brucella that infects dogs, is not actually the type of Brucella usually that affects livestock or humans in terms of the sort of type that accounts for the majority of infections, but there is still that risk there. So it's worth bearing in mind. And I think the big thing with Brucella is that a lot of dogs can be what we call asymptomatic carriers. So dogs can potentially be carrying it and we don't even realize. But for the ones that do have clinical signs, the difficulty in terms of diagnosing it is that there's so many different clinical signs they can have, from the reproductive signs, which I think are advertised more globally, including abortion in pregnant bitches, but then also things like disco spondylitis. So in theory, maybe any dog that's got an import or export history that's got back pain, maybe we should be really worried about Brucella. So, and the sort of scary thing with it is there's no proven treatment for it. So it's sort of that question of, well, what do we do? Or should we be recommending euthanasia in these patients because of the zoonotic risk? Or are we telling them to manage it, but just be super careful? I think that's the thing that's the really difficult discussion around it, isn't it?
Yeah, and then if you've got staff that are potentially pregnant,
Mm,
you've got that extra additional kind of extra stress. And staff, you made the really good point. Brucella canis is not Brucella. Is it melitensis, which is the one that we all know causes abortion in
think
sheep?
so.
I think it's the one that's more associated with human zoonotic disease, but Brucella canis isn't really,
Mm,
as nearly as I don't think there's been any fatalities in humans in the UK from Brucella canis, and I think it's
mm,
extremely rare to see transmission. But if you're pregnant, or you could be pregnant, it's just going to play on your mind, isn't it? So yeah, we need to
yeah,
get our head around risks and how we deal with it. And this is the problem, because we don't also want to create alarm, because if we get a positive, we've now got an owner. We now need to talk through an owner. Is that positive a genuine positive? Because
that's
that's
the
the other
thing. Yeah.
problem. The testing is
It's
not
false
great.
positives. Yeah.
Yeah. Yeah.
Yeah.
So
Yeah. I think it
yeah,
happens
this is
really
why it's such a
often.
cool topic. Yeah.
Yeah,
Yes.
and they're actually now saying as well that apparently even the prevalence of Brucella, that there is a really small population of dogs in the UK that have never travelled, which are apparently positive for Brucella, which is quite scary. So now we don't even have to be just worried about the ones that are being imported or exported. It's apparently there's a prevalent. I mean, it's tiny. It's they say that
But
less than 0.
it's not endemic. It's not endemic in the UK. I'm
No,
right
it's
in
not
saying that? Or am I
endemic.
wrong in
Yeah.
saying that? Yeah.
No, it's not endemic. So it is still considered an imported exotic disease. But I think because of probably it's been transmitted to other dogs in the UK from those imported dogs, probably, or some of them, it's estimated that like just less than 0.05% of the UK dog population have never travelled and still have Brucella. But the thing is we're never going to know that number because the dogs that have never travelled and are subclinical, so have no clinical signs, how would we even know? That's the tricky thing, isn't it? So it does become a bit of a scary disease.
It's
Yeah,
like the bogeyman, really, because yes, it's there, but it's not really causing a
yeah,
apparent disease in humans.
yeah.
So it's quite a big feature of modern life, isn't it? That we have things to worry about.
Mm, yeah,
Risk wise, I mean, if you look at risk, it's probably greater risk being bitten by a dog, getting cat scratch
yeah.
disease from a cat bite, getting
Mm,
COVID from a client. I think these are all real risks, but that doesn't.
mm,
Don't want to negate the fact. I think a lot of the Brucella issue is about we need to identify it coming in and stop
mm,
it in its tracks, so that we aren't, because obviously in the last 10, 15 years we had so many dogs from Eastern Europe
yeah,
and countries where it is endemic, and
yeah,
we probably have had our. I was going to say we've had our trousers down. That's not the right expression at all. We've had our. What is the expression? Anyway, we haven't been on guard to stop
yeah,
Brucella coming in. The number one objective for me, anyway, is making sure Brucella isn't endemic in the UK and catching dogs coming from abroad.
yeah.
There's also the thorny issue of dogs that go on holiday to Spain, come
Mm,
back. Should they be Brucella tested? Do we need PPE for them?
yeah.
So I don't know where have you had this come up in your clinical practice yet?
Yeah, I think the difficulty is as well is that you can test them, but there's the tests themselves are not super accurate. So you can get a lot of false positives. And so I think sometimes you can get false negatives as well. So it's how reliable are they? Should we be testing ones that don't have clinical signs? But in terms of the clinical signs where I would be wary, so in terms of when should you be worried in practice, if you have a dog with potentially reproductive signs or signs of discospondylitis. So by reproductive, I mean either purulent vulval or preputial discharge. You might have uni or bilateral epididymitis, testicular atrophy, orchitis, prostatitis. You might have stillbirth in your pregnant bitches, infertility sometimes. So dogs that are trying to get pregnant but are really struggling, that have been imported, fading puppies that from bitches that have been imported. And then your discospondylitis, so back pain, neck pain, lameness, neurological dysfunction, weakness, etc. Those ones that have been imported, yes, I possibly would be testing for them now. But again, I would be warning the owners if that comes back as a positive, is it actually positive? And then you have to go down the route of thinking, oh God, they're going to be thinking, oh my God, what am I going to do with my dog? Do I need to euthanize it? What, how are we going to handle it? Where am I going to hospitalize it? In the time between you getting that false positive potentially and then getting a firm result, it's really tricky, isn't it? But I think in terms of protecting ourselves and our staff and the clients, we need to be being careful. So
What you said, yeah, and I agree with you. So the patient side tests that we have in practice, you've got the one that tests for IgM, which is the antibody that comes right at the beginning
Mm.
of an infection, because IgG takes a few. This is where you get the 12-week. Takes many weeks to kind of hit in with the IgG antibody response. So if you've got these patient side tests looking for antibodies, if you think it's a recent sudden infection, you do the IgM one, which begins with M. That's how I remember it. So it's like the mega RSAT test. And so there's two different ones. There's the IgM one, which is worth having if you're looking for recent infection. So let's say it has been bred and therefore it might have acquired brucellosis from breeding. But then you've got the dog that's been in the UK for a year. You don't want the IgM one at that point. You're better off with the IgG one. But and that's more like the lateral flow test where you have the line, and that's the fast test, is it? I think now, but those two tests are the ones that have got all the false positives as well. So they're the ones, like you said, I think only use it if you've got a strong suspicion. It's been breeding, it's aborted, it's got back pain, and it's from Romania or whatever. If it's ticking quite a few
yeah.
boxes, because like you say, you don't want to be using that willy nilly, getting false positives, and people are
Mm.
euthanizing their dog before we've had the confirmation from the
Yeah.
external lab through, and
Yeah.
you're just creating a whole nightmare for everyone. So
Yeah.
I think that's what you said. I think only test high risk with those inpatient kits.
Yeah.
Otherwise, low risk ones send off to the external lab because
Yeah.
the sensitivity is really good and the specificity is actually much better with the external lab where they're doing a
Mm.
more controlled test. Is that where you see it with this testing?
Yeah, and I think the difficulty is as well is that say if you get a false positive in something that's aborted, but the dog is otherwise well, then what the hell do you do then? So they're sometimes recommending that if you've done that type of serological testing and it's come back as positive, if the dog is otherwise well, they sometimes say that if you want to, what you can do is send them home but completely isolate them and warn the owners of all the risk and then tell them to retest in 4 to 6 weeks. But
That's
like
terrifying.
who's going to want to do that? It's so tricky. And then they say that you can do this PCR as well, which they say that is only recommended in certain cases. And generally, if you get a positive result, it means that that patient is in the early states of infection or has acute clinical disease, but a negative one doesn't rule it out. So basically, you use it to confirm, I think, but you don't use it to completely rule it out. But the difficulty with testing is really tricky because there's no treatment, it's, well, what do we do? Should we be saying to people that these animals need euthanizing? And yes, maybe in the ones that are clinic really unwell, then that becomes a really different situation. But if you have a dog that potentially is shedding this pathogen, which people can, in theory, become infected by, but they're well, what do we do then? Like, are we saying to people, it's really risky, and if you want to do it, just keep her completely isolated and be super, super careful around this dog? Or do you say put it to sleep? What are we doing? I don't know. It's tricky. And the bottom line is if you're ever worried, if basically remember the clinical signs, test the ones that you think could likely to have Brucella. If you come back with a positive test, say to the owner, I need to do some more thinking. I need to speak to a referral centre. We're going to put in biosecurity measures in the meantime. Isolate them, wear your PPE, be super careful, get a referral centre on the phone and just say, what should I do next? Because they're going to be the ones that are most up to date in terms of how you should be testing, why you should be testing, what could be going on, do they think it's likely Brucella, etc. So get on the phone to someone like an internal medic somewhere.
Yeah, I think I like what you're saying. And do you know what? If you think this Brucella thing isn't relevant to your clinical practice, it really is. Because when your
Yeah.
patient goes to the out of hours service and the vet's saying, have you had a Brucella test? Oh, no, you haven't. I'm not going to see you. I'm going to do PPE. And that's going to cost you extra money and da-di-da-di-da.
Mm.
Or if you go to a referral, if you refer your patient and the referral hospital looks at the history and goes, well, you've come from Romania and you never had a Brucella test 3 months after you came back to the UK,
Mm.
then your client's not going to be happy with you. So I think for all of us now, we have to make sure we communicate to clients that, look, it might be incredibly low risk, but I don't want you to have trouble at the out of hours centre or the referral centre because we haven't done this. And look, yes, your dog is
Mm.
probably negative, but it's worth testing them.
As well as it's probably worth mentioning to clients that there is a risk of getting a false positive before you do the test. Because if you do it and then you panic them and say, we think it's got Brucella, and then it comes back as negative, if you've not warned them that that could happen, then you might put yourself in a bit of a situation. So I would just be a little bit careful with how you phrase it to owners, but not to the point where you want to say, oh, well, you're going to get loads of false positives. So they're going to think, well, I don't want you to test it then because what's the point? So just be a bit careful with the way that you phrase it.
So this is where I get back to the nuance too. If you have let's call it a Chihuahua that goes on holiday with its owner to Spain
Mm,
and it only eats chicken breast from Marks and Spencer's and it doesn't touch it. Do you know, I'm guessing it's not being rampantly sexually active when it's on holiday. I
mm,
think when it comes back from its holiday in Spain, I don't think we have to wait 3 months and test it in that context. I
mm.
think we should probably use our judgment because if you're a vet in Spain, I'm guessing you're not testing every dog you see every 6 months or whatever
No.
you might do. Surely it's more like, well, if there's risk factors.
Mm,
But if you've got a dog that scavenges everything, it's free roaming when you're on holiday and it might have eaten some aborted uterus somewhere or whatever, or mated, or it's male entire or whatever, then okay, clearly there are risk factors on that holiday to
mm.
Spain. I'm guessing that doesn't happen very often, but I think this is where we don't have this black and white approach, but we have to use a little bit of judgment.
Yeah, and realistically, it's going to be more likely in your rescued dogs or dogs that have been in contact with other rescue dogs from a different country. So that's probably where it's most likely. But I think generally in the pet population, the risk is probably more slim. But yeah, it's just to say it's not likely that you're going to get a positive case super regularly, but just be careful because you don't want to miss it when you do have one.
There are some guidelines actually. The BVA have got some really good guidelines on this if people want to look in more detail at what organisations are saying. But if you have an asymptomatic dog that's been in the UK for 3 years and then you test it
Mm.
and it comes up positive, yeah, you need to be pretty much already there with how you're going to handle that
Yeah,
because
I
that is
think
some tough chat.
again, it comes down to your practice policy, doesn't it? I think if you've not got a policy for these things, get a policy in place so that everyone's on the same page. Because then, if any dog comes in when we're suspicious of these symptoms, this is what we do. But there we go. Hopefully, that's a bit of an insight for you. Okay, so roundup time. We've covered loads today from vaccination protocols, new injection sites. We were going to cover neutering controversies, but we'll do that in a later episode because we chat too much. And then we've just gone over the big scary Brucella and what we need to do in practice.
We hope as ever you've enjoyed listening and remember to get in touch if you have any comments or suggestions to help us improve these pods for you, any topics you particularly want to cover.
Yeah, and we'd love for you to get in touch. But for now, thank you for listening. Join us again next Sunday for our extra bonus episode of the month, where we'll be taking a deep dive into toxicology, just in time for the lucky listeners who are working over the Easter bank holiday, like me.
Yes, we've all seen plenty of raisin, chocolate, and daffodil toxicities before. Tune in next week to hear us chat about these in depth and walk you through these cases.
We're looking forward to it already. Until then, it's bye from me.
And bye from me. Take care. The content presented in the Chatty Vets podcast is intended for licensed veterinary professionals and is for informational purposes only.
Views expressed are those of the host and guests and do not substitute for clinical judgment or individualized patient care.
Drug dosages, protocols, medical advice discussed should be verified against current literature and manufacturer's guidelines.
Us and its creators are not liable for any errors, omissions, or adverse outcomes resulting from the application of this information.
Always consult relevant laws, regulations, and institutional policies in your practice. Listener discretion is advised.